So a good place to start this conversation is to again remind ourselves that patients who have MASLD do not just have MASLD. Virtually all of these patients, as Ajay showed you, have comorbidities which are systemic. And these are listed over here, so we know these patients may have hypertension, vascular disease, diastolic dysfunction, type 2 diabetes, or chronic kidney disease. The reason these are important when we talk about therapeutics is because these represent competing threats to life. And so it sort of doesn't make sense to fix one of these while ignoring the others if the other things are going to actually kill the patient and lead to morbidity or mortality. So there's already a substantial body of literature to give us best practices in how we manage many of these comorbidities, because people have recognized these as important drivers of population outcomes for a long time. And these are all listed here. I will not bore you by reading each and every one of these. But the point here is that the one thing that benefits all of these different things is virtually to treat the root cause, which is adiposity. Because adiposity links to metabolic stress, which drives a systemic inflammatory and fibrotic state, which is reflected in different end organs in the way of hypertension for blood vessels, atherosclerosis, diastolic dysfunction for myocardium, and MASLD in the liver, CKD, et cetera, et cetera. So this has been the driving force for drug development in obesity, where we're rapidly moving towards from single agents which are injectable to oral agents, dual agents, triple agonists, and eventually combination therapies. So my goal today is to see how all of these fit in along with liver-targeted therapeutics for the treatment of MASLD. So the baseline standard as we go forward and we think about these molecules, where the field sits is that for a drug to be a player in the field, you have to have at least a 10% or greater placebo-subtracted weight loss in randomized trials of a year or so. And then it has to or produce greatly more than 15% weight loss in over 50% of the patients, in addition to lifestyle intervention. Now let's switch gears from talking about obesity and where the bar is set and think about MASLD. So I like to think of this as a population pyramid, where I show people with different prognostic strata, starting from the base, which has the best prognosis from a liver point of view, all the way to the top with cirrhosis, which has the worst prognosis from a liver point of view. Now, majority of patients actually sit in the lower strata because they have either steatosis alone or they have steatohepatitis with early fibrosis. You saw the data from population-based studies, 29% prevalence of MASLD, but multiple studies showing advanced fibrosis in 1 to 2% only. So let's start at the base, and this is a concept that we recently introduced, which I refer to as bottom-up therapy for MASLD. So if you start at the bottom of the pyramid and ask the question, if you wipe out steatohepatitis or steatotic liver disease in this population, will it prevent progression to more advanced disease? Will it take care of the problem? Because this is where the bulk of the population with MASLD. Tomorrow's cirrhotics are all sitting in this green bucket down here today. So of course, the most powerful weapon we have in our disposal are these GLP-1 receptor agonists, which have a number of valuable effects in the setting of this metabolic dysfunction, from cardioprotection, improved coagulability, decreased dyslipidemia, improved glycemia, improved appetite, decreasing the appetite, getting you to lose weight, and actually reducing vascular inflammation. And you can see the data over here with semaglutide showing very nice dose-dependent weight loss. This is the data on which the drug was approved for obesity, and now is sort of almost the gold bar against which all new therapies are being compared to. Now, variety of GLP-1 agonists regardless of the individual GLPs, have been shown to reduce all-cause mortality and hospitalization for cardiovascular outcomes and to flatten the decline in eGFR in patients with type 2 diabetes. This has now been expanded out in the SELECT trial in a non-selected overweight obese population producing 10% cardiovascular outcome benefit. So really there is no controversy here. This is now one of the given truths in medicine that this class of medicine drugs have fantastic effects on the cardiometabolic outcomes. So the progression from semaglutide, which is a monotherapy, to now jump forward to retatrutide. This is a triple agonist, which in addition, it's a single molecule, but it actually binds to GLP-1, glucagon, and GIP. Now, whereas GLP and GIP have no receptors in the liver, all the action is in the muscle everywhere else. Retatrutide through glucagon actually also targets the liver. And what you see here is that this has the highest medically induced weight loss. In this phase 2 study, we showed that there was about a 24% weight loss. And in this population, this is an obesity trial, there was a subpopulation that had fat in the liver. And what you see over here is that 86% at 6 months and 93% at a year actually had no evidence of steatotic liver disease anymore. Their MRI-PDFFs were below 5 and their AST/ALT were normal. This was accompanied by some drop in PRO-C3. Remember, most of these people did not have significant fibrosis. They didn't have NASH. This was sort of the lowest bar. These are mostly people with fatty liver. And we know there are population-based data that show that GLP-1 receptor agonists are actually reducing all these important cardiovascular benefits, even in unselected obese and type 2 diabetes populations. So we have actually got now something to offer to people at the bottom, because historically all the practice guidelines only focused on people with fibrosis because that's the one with the greatest risk of a liver outcome. But potentially now we can actually attack it right at the base, treat all the risk factors systemically, and hopefully this will reduce progression to more advanced disease. Now let's ask the question, will weight loss actually take care of the problem who has now started scarring down their liver, the at-risk MASH that Sven alluded to? So this is a paper that has been sort of referenced hundreds of times. So I thought it would be worthwhile to make a couple of points here. So these are the original data from the study, and from this came this concept that 5% weight loss improves steatosis, 7% improves steatohepatitis, and 10% improves fibrosis. But as you can see over here, of the people who did not resolve steatohepatitis, there were quite a few people who had substantial weight loss. Furthermore, if you draw a line at 10% weight loss, and you go to those whose fibrosis got better, the blue dots, you will see the majority of them had less than 10% weight loss. So, this whole 10% thing is a little bit of a myth, and this is why if you proves the point, if you repeat the same lie enough number of times, it becomes the truth. So I'm here to really stand up and argue against it. So weight loss does not guarantee NASH resolution, but weight loss does improve your chances of NASH resolution and fibrosis improvement. And fibrosis improvement is a complicated process and not a simple function of weight loss. Why? Further proof. Look at semaglutide. 59% NASH resolution shown on the left, but on the right, no signal for fibrosis benefit. Here, 14% weight loss. So clearly the 10% idea that if you just lose 10%, you'll be great, does not pan out when you look at the evidence. And when you look at obesity surgery, this is a beautiful study from Lille, and where they show over here at 5-year data based on MASH resolution according to weight loss, and you can see 90% of people resolve their MASH. But if you look at fibrosis, most of the fibrosis benefit is when you have early fibrosis. At the very top, the cirrhotic bar remains about the same, and in the advanced fibrosis, 50% of the people at 5 years still have bridging fibrosis. Now, it doesn't mean that we still know all the answers for sure. So weight loss is good, but it won't get you all the way there. Now, having said that, this is a very recent data from Amin Ali showing bariatric surgery actually in those with compensated, even with compensated cirrhosis, regardless of not improvement of fibrosis, actually the outcomes do tend to improve compared to medical control. So I think this is an evolving story. We'll keep an eye on that. But the point is, weight loss alone may not get you there once you start scarring down your liver. You need liver-targeted therapies. And resmetirom is the first drug. It's a thyroxine beta receptor, acts by improving mitochondrial health, and by that reducing inflammation and fibrosis. And these are the data on which the drug were approved. At the left, you see with conventional staging, there's about a 12% placebo-corrected fibrosis improvement. And then you can see all the other ways of looking at the fibrosis and worsening. But those are really, from a regulatory point of view, not so relevant. Now, when you look at how fibrosis improvement has become now the reference standard for how we assess the value of drugs in patients with NASH with fibrosis, this is the landscape. So what you need to, because all these studies are done differently, different populations, different approaches, the best way to evaluate this data is to look at placebo-corrected differences, which is the black part of the bars. And what you see over here are these FGF21s have now jumped up as sort of important molecules that actually have very significant fibrosis benefits. And recent top-line data from Akero presented at EASL showed that when you follow this particular study, where at 36 weeks they had 41% fibrosis improvement, by at week 96, that number is 75%. Imagine 3 out of 4 patients actually having regression of fibrosis. That's really, we're making serious progress. So a lot of excitement around these FGF21s. And as you can see, there are data for other, pegozafermin is another FGF21, lanifibranor is a pan-PPAR, whose phase 3 data, phase 3 trial is being completed. We hopefully in a year's time we'll have the data. And then you've seen the resmetirom. OCA has development for NASH has been stopped, and you've seen the semaglutide data. What's new is that there are these GLP, GIP, GLP glucagon co-agonists that have come up. So these are data for survodutide, which is GLP glucagon dual agonist. It is now out in New England Journal. Again, you can see 60% NASH resolution and up to 50% or a 30% placebo-corrected fibrosis regression in those who actually completed the full study. Similar data for tirzepatide showing very nice NASH resolution and also fibrosis improvement, as you can see. What is interesting is neither of these molecules showed a great dose dependency, and it could be that even at the lowest dose, you're getting maximum therapeutic benefit. Now, coming back to these FGF21s, not only did I show you the fibrosis benefit, but they actually substantially improve the atherogenic risk profile. Yesterday, we talked about dyslipidemia, etc. And these are data for pegozafermin for hypertriglyceridemia. And what you see over here is that it really produces a nice dose-dependent decrease in triglycerides, and this non-HDL reduction of about 55 should translate into a 30% reduction in cardiovascular death. This nomogram shown on your right is actually a very important diagram in cardiovascular medicine and often used to assess the potential future benefit of drugs in development. So if you put this out and look at the hepatic and cardiometabolic effects of drugs, you can see the GLPs have obviously great cardiometabolic effects. They have improved NASH resolution, no fibrosis, but next generation, you're beginning to see a signal for fibrosis improvement. And they're pure liver-targeted therapies, which of course do that. Now, of all the other drugs that are there for diabetes, metformin, DPP-1, and all of those have fallen behind. But importantly, the insulin, we try to minimize the use of insulin because it leads to weight gain. So the use of other classes of molecules for diabetes control is becoming very important. Finally, we have not yet made a breakthrough for those with cirrhosis. And this is, I think, where the next summit for us really is from a therapeutic perspective. While we have a lot of options now for people with NASH with some degree of fibrosis, and certainly for those at the bottom, we have very effective ways of managing those patients. So this is something that's going to come out with the American Diabetes Association new practice guidelines that we're putting together, and basically shows sort of the choice, your menu of options for the treatment of obesity, diabetes, and MASH based on how much fibrosis you really have. And note that many of these are to be avoided when you actually get decompensated cirrhosis. So with that, I will stop. I thank you for your attention. And hopefully I've given you an overview of where the field is headed. Thank you.